Hello, welcome to Top Tips at 2 Years. This is a webinar related to the 2021 curriculum. I'm Keith Jones, Surgical Director of the ISCP, and hopefully over the next period of time, I, with the help of my colleagues, that's Kirsty Moslowski, who is representing ACID, asking questions for the trainees, and Tim Jones, paediatric cardiac surgeon, chair of the cardiac SAC, is going to ask questions from the trainer perspective. So I'm really grateful to your help, Kirsty and Tim. Welcome, and hopefully we can cover some of the things that we've learned so that people can utilize those tips to optimize their portfolio, how they utilize the 2021 curriculum, and hopefully also get the MCR done in a better way. So we're going to do this with alternating questions. There'll be some slide support for what is a pre-record, and there'll be hopefully some additional questions. So if we might as well start off. So over to you, Kirsty.
So the first question the trainees have is, what are the most important areas of the new curriculum that we need to be aware of?
Well, it's a great question. I think just being aware of the curriculum and what it entails as a whole is really important. So I would be telling anyone to read the curriculum, and the easiest way to do that is to go to the front sheet, the first part of the ICP. You don't actually have to enter, you just go to the carousel. The first page on the carousel is the surgical curriculum page. Click on it, go to your specialty, and that includes core, and open up the curriculum. At the end of the curriculum pages, you'll find the appendices, and the appendices, so appendix 3 has got all of the critical conditions listed. So those are the things that should have been completed to level 4 for the completion of the syllabus and the curriculum to award of CCC. So those are the things that are critical knowledge to know, and they're specialty specific. Appendix 4 covers all of the index procedures. Those are dealt with differently by different specialties. Some specialties have grouped the index cases. Some spaces have just kept them all as individual, but it's all clearly documented how many you should ideally have undertaken to have covered the breadth of the curriculum. That's what the index cases are there to do, to ensure that you've surgically covered the breadth of the syllabus within the curriculum. They're all listed in appendix 4. Cumulatively, they all come together, and the bit that often everyone wants to know is, what do I have to have done to prove that I'm ready for certification? That is very clearly listed in section 5.4. So appendix 5.4 component is the certification requirements for your specialty, and easy access. Go to look at those. I would definitely do that at as soon as you start, and probably at the start of each phases. And if you're ever doing a gap analysis, and we'll come back to that frequently, I think doing a gap analysis of your knowledge, it would be really sensible to go and look what you're supposed to have done at the your specific level within the syllabus and curriculum. And if you don't understand or you can't find it, ask, be it your AES, your TPD, or your SAC liaison member. All should be approachable to be able to ask and get guidance. And if you can't that, ask me.
Good, thanks, Keith. Now, what advice would you give to a trainer for the best way to carry out an MCR assessment?
Again, great question, Tim. I think the important thing is to understand how it's split up into the generic professional capabilities, the CIPs, capabilities in practice, and how it all comes together. I think it's really important to know what stage of training the trainee is in. So the trainees, the expectations, so the GPCs are assessed as being appropriate for phase. So you need to know where the trainee is. So if you're assessing a core trainee, you should be assessing them as appropriate for phase if they are. They shouldn't be getting descriptors for development from the consultant because they think it should be that they're ready to be a day one consultant, which they won't be. And so I know that has been something that has been raised. The core trainee is concerned that they're being shown as requiring development because they're not at consultant level. Whereas actually for the GPCs, if they're appropriate for phase, they're doing the right things as they would do, it should be at levels 1 and 2 of training, then there shouldn't be any descriptors to utilise. And so trainees at any level can be appropriate for phase, or they may have some points for development. And if they do have points for development within the GPCs, that's where you would utilise the descriptors. If you feel that the trainee is appropriate for phase, but you want to help them develop to the next phase of training, then you can use free text and write free text in the box. Don't use the descriptors, list them as appropriate for phase, but outline briefly in a sentence in free text how the trainee may cover that aspect, that GPC, to develop to the next stage of training. So very much utilize that combination. I would use the descriptors where development is required. If development isn't required, but you do think there's some advice how to go on to be appropriate in the next phase, then use free text. If the trainees are doing really well in a area and you want to reflect that, again, use free text, or a little cheek if you think, well, one of the descriptors does cover that, is that you could cut and paste the descriptor. You don't actually have to click on the descriptor, and that way you can use the wording if it's appropriate, but it doesn't come up as them requiring development. So that's in relation to the GPCs, and I think it is important to have considered those. If you're just a clinical supervisor, I'm not saying just, but if you are a clinical supervisor and you're doing the GPCs, GPC 6 to 9, just remember to consider the trainee clinically as you see them, because the educational supervisor can add in the additional information or referenced supporting information that the trainee may have put into their portfolio related to teaching or research per se. For the CIPs, when you're undertaking MCR, again, it's really important for the trainer to know the trainee's level and the phase. That is shown well in the charts on the curriculum, so that you'll know the level to which you're assessing. So what you don't want to do is have a trainee that's in phase 2 and you think, well, they're great at that, and list them off, and all of a sudden find that the trainees turn around and say, well, that says that I'm appropriate to finish the phase of training. Clearly there would need to be some points of development, and as well, it's important that trainees understand the level that they're getting assessed to, and that will be a part of the reason for comparing that to self-assessment. So it's really important to know the trainee's level and phase, so that you get the appropriate representative supervision level. When you're using the supervision levels, if you put anything less than a level 4, so for most of the trainees in phase 2 certainly, and for a lot of phase 3, there will need to be the use of descriptors or free text that show, but mainly the descriptors, to show how the trainee would develop. Now, some things they'll be doing really well, and you can show that. So I would suggest using 5 of the descriptors. Some of the shows what they do well, some things, the points they'll need to develop. So early in phase 2, if there's something that they're doing well, then use the descriptor, but use the other 4 to show how they need to develop towards being a level 4. At the end of phase 2, you may find that there are 2 or 3 things that they're doing really well, but a couple of things that are points for development. And again, as the level 7, the first part of phase 3, there may just be 4 things that are doing really well and just 1 point really to concentrate on to development. For say for CIP4, the in theatre operating aspect, that may be some technical skills. And remember that you're using those descriptors and giving them some defined development for the next 3 to 6 months for that phase of the MCR. To make it easier to start with the MCR, we said this at the start, and I still think this now, it's really important that everyone writes down a pen portrait. How do they see the trainee? And that starts the discussion between the at least 2 clinical supervisors that are there in the room. Ideally, it's best if it's 4, and then you can agree the points made and the descriptors used, and that what you should remember is that the points that you're raising to the trainee are essentially the start points to the feedback discussions. And so there should be some developmental ideas, but some of those are how we're going to do that may come from the feedback discussion. Again, that's a really important part of the MCR in that it enables trainee development. That's what the MCR is. It's part of trainee development. So it should be undertaken by at least 2 supervisors. And the more there are, the better it is. And the sort of greater protection of the consultant opinion comes with the more people that are there, because you can then give, I think, the more people, they're more in-depth developmental feedback. Sometimes it could be slightly challenging. That meeting should be face-to-face. Late contributors, those people that can't attend, should be sought from the named supervisors. That's within a 48-hour period, which very shortly is going to be from 48 hours working days and not include a weekend. And it's important that those people come back in and give some defined points. That allows the MCR to be signed off by the AES, and the AES should, to give a good MCR, be making some active comments, referencing the portfolio, and able to show what ISCP activity has been undertaken. That AES noting is the point whereby we can, that's us at the ICP, reopen an MCR to, if there's a question, pushback, feeling it doesn't describe a trainee appropriately, trainee upset about some of the comments made, or the program director per se, or the ASN says on reflection, I want to add something else. We at the ICP can reopen the MCR to that stage, and then we can mediate with comments, or any disagreement could be mediated at that point. But further to that, we're not reopening and we're not getting rid of any MCRs. The other thing that's really important to say from a trainer point of view is to recognise the learning assessment, the learning agreement, and how the ASs can use the learning agreements to set the objectives from the MCR. They'll look at the self-assessment and the MCR together, set the learning objectives, and therefore it is, and we'll keep coming back to this, a really good way for trainees to highlight something they want to talk about and get to be part of their development by putting it in their self-assessment. So it's part of the discussion with their AS, and then that becomes part of their discussion with their learning agreement. And then the next MCR, it'll be something that's assessed.
Thanks, Steve. That's great advice, particularly about considering the phase of training for the trainee. And I really like the idea of the pen portrait to start the discussion around the MCR. So that's certainly something I'm going to start doing. Now, Another question, guys. What's the meaning of the CIP5, the multidisciplinary working? And how can our trainees and trainers evidence this and assess it?
Well, I think CIP is there to essentially show team working, the ability to work within a team. And that isn't just the traditional firm, it's the people that you come across within your everyday activities that essentially are part of the patient journey of the people that you treat within your specialty. So it does include the ability to discuss, take advice, incorporate that advice into management plans within what we see traditionally as MDT meetings. But it also includes the incorporation of working with para-specialties, be that on the wards, in the outpatients, people that you might refer to, how to optimise patients both pre and post intervention, and how to interact with other clinician colleagues that are part of the patient journey. Now, some of the specialties, so yours and paediatrics, have that extended additionally by having CIPs that look at how the patient in the acute care environment is managed for the specialties, so not paediatric surgery or cardiac surgery. That component, that how is a patient managed and incorporated on the intensive care environment, how you might interact with colleagues, that's included in CIP 5, as much as also it will be included in the CIP of managing the inpatients. But it's the multidisciplinary incorporated working between specialists, I think. So I hope that clarifies that aspect. And again, it is because of recognizing the difficulties of developing that skill overall, and some of that I know that people feel it takes a long time to develop that confidence of how to interact with other specialties, but at perhaps different grades. So a ST7 interacting with an experienced intensive care consultant or an experienced interventional radiology consultant may take some time in relation to the competence, but that's an important aspect to be reflected back on, because it's a developmenting skill set. So hopefully that answers that aspect.
Yeah, it does. That's very helpful. Thank you.
Over to Kirsty.
Yeah, sorry. So regarding the MCR, we have to do a self-assessment section of the MCR. Could you tell me what is the benefit of a trainee doing a self-assessment? Surely we're more interested in the trainer's feedback.
I mean, I can see that, but for it to work and work well, your trainee view is crucial to the point of assessment, because it's all based on feedback. So you have to know or think you know where you are for that feedback to be beneficial. And it's important for you to consider all of the issues. And that's why the self-assessment is the same as the MCR. The idea of doing the self-assessment is that you can showcase the areas where you think you're doing well, and you can use WBAs to cite that, and you may, as you will have done, a multiple source feedback, that MSF will give you bits that you can put into your self-assessment to go, this is the bit that other people think that I'm doing really well. And I'm pleased because I think that validates, because I think I'm doing well at that. And it's also, therefore, it's able to show insight into the progression. You know, it's that you can't do it wrong. And the idea about getting the feedback, if there's a discrepancy between your self-assessment, you know, I say any trainee self-assessment and the MCR early on in training, then that can be a good thing, because it may be there's a misinterpretation on either side about the levels that you're assessing. So you can then, within the feedback, see which levels you're assessing against and try to rationalize that, explain it away. For many trainees, they think that they should be able to do more under indirect supervision, or without any degree of supervision, and realize from a consultant's and trainer's perspective what they mean by indirect or direct supervision. The other aspects about the self-assessment, which are very important, is that when you look through it, it shows an honest interpretation of where you are as a trainee, and that again is really important for development. To admit where you are, where you need to develop, allows you to develop, and that can occur, and realization that can occur from the point of comparison at the time of when you're doing the MCR is being done. I said we'd come back to it. I think the self-assessment is really important from a training point of view, because if you can compare yourself to where you should be against the curriculum, it's a perfect gap analysis. So start, what do you need to do to develop? How are you going to do it? The how are you going to do it is going to come back from the feedback conversation, but the where you are is is that self-reflection. So compare your portfolio against the appendices talked about before. So 3, section 4, 5.4. See what PBA requirements were or are. See if they have changed. If you've done them before and that's now been enhanced, you may think, well, it's not possible for me to go back and redo that from previous placements, but you can write that in your self-assessment. You can raise that point. That point will be discussed in the feedback. That point can be addressed in the MCR. So you don't necessarily need to go back and say, well, I've got to go back and do another level PBA 4, whereas your trainers will see that you've done it previously. So I know that some, say, plastic surgeons, they know some aspects about burns per se. I've done that placement, but that can be discussed in an MCR that we think an appropriate knowledge it can be addressed. It can be addressed at a subsequent ARCP. And therefore, if you're saying, well, how do I do that? Well, put it in the CIP, but use free text. When you're discussing the gap analysis with your AS at your objective session, you can ensure you then get an action plan to address any of those points. And the really good thing is that you can highlight how you're going to do that, utilizing your best learning style. And part of the aspect from a trainer's point of view is to look at self-assessment and say, well, what is their best learning style? And sometimes the trainee just has to tell their supervisors what their learning style is, and that would come away from their objective settings and the feedback sessions. The AES's job to go to the colleagues and go, let's try and do this differently. This is the best learning style. So you can definitely use your self-assessment as a prompt to your lead clinical supervisors, to your AES, to your TPD, also of how best you can be trained, but also, I've done this, I've done my self-assessment, I'm due an MCR, because they'll see that, and due an MCR, and that prompting comes up.
Brilliant, that's really helpful. Great tips, including how to document previous PBAs. I know a lot of trainees, we find it very hard to both critique ourselves, but also kind of big ourselves up. So what is expected of us in our self-assessments?
Well, no more than the fact of giving an honest, balanced appraisal of where you think you are. I sometimes think I need to reassure trainees that what you write in your self-assessment, it's not a journal for publication. Not everyone's going to read it. It's your representation, and it'll be looked at by your supervisors, and it stimulates feedback. It allows you to undertake a gap analysis. So if trainees don't know how to approach this, approach it as a gap analysis. Say, this is what I think I need, or this is where I think I am. and then look at the syllabus and think, oh, actually, this is where I need to be, and then that helps the conversation. So if you start your gap analysis and then you evidence it that proves where you are, you'll actually identify some of the aspects that you'll need to point for to develop. And the more things you identify, the more things that can allow development, means the quicker and the better progress you will make through the system, and the more likely it will be to go well. You know, I've never seen anyone struggling who's got a tidy ISCP. And that's sorry, and that was going to say just finally, remember that you can use the learning agreement as a from the self-assessment. So the self-assessment gets discussed in the learning agreement, and then you'll come up with a plan of how to address or evidence something. So address a need for development or evidence that I've done this before and I'm not going to be able to go back and do it again. Do I need to? No, you don't.
Yeah, that's really useful. I mean, it highlights the need for really open and honest self-assessment, and it gives the trainees the opportunity to really personalize individualize their training. But how about when it comes to the MCR process? What impact should the self-assessment have on the MCR process?
Well, it's part of the feedback that and I've said before. I think the feedback is the most important part of the MCR. So when you're as a trainer, when you're giving feedback, you can see what the trainee feels, where they feel they are, where they feel they should be, and then compare that to how you and your colleagues think they are from the MCR. I would hope, and that's certainly from the evidence we've got over the last 2 years, that does appear to be the case, that the GPCs and the CRPs are well placed, and that any discrepancy would indicate the need to address either under or overconfidence. We're seeing that they match quite well on the whole, and that's what you'd hope. But if there is a big discrepancy, it stimulates a conversation. You know, there are some, not to go into it greatly at this point, there are some perceived gender differences as to how people see. You know, some people think more highly of themselves. Some people underscore themselves, but those are important things to deal with early on, I think, in that self-assessment MCR comparison. You know, some of that may fluctuate over time, and you can use that as trainers to see that if you have a trainee that always has been very consistent and honest and reflected highly upon themselves, if there's suddenly a dip, something else is going on. You use that as a prompt to where a trainee may need extra support. Equally, there's suddenly it flicks up and there's a bit of overconfidence aspect. There'll be a reasoning in relation to this, but it allows the trainer to recognise that and come up with a development plan agreement with the trainee. I think that it's also, from the trainer point of view, important to see what the trainees consider to be the main issues. Now, they may be very different to that's represented in the MCR, and part of that may be that the trainee feels that they're not able to undertake learning in the best style for them, in which case there could be some changes made. But also the trainee may feel that they're developing, or there is a developing issue that they're making them concerned that it just isn't being addressed in relation to some aspect of their skill set. And putting that in the self-assessment from a trainer's point of view, reading that means you're going to deal with it. And so that's what I think from a trainer's point of view, it is the AS or whoever it is that's giving the feedback will get to see that, and certainly AS within the learning agreements will get to see that. And I think as an AES, having read that, you should reflect that back to your trainer group, to the other clinical supervisors, so we could optimize the way that the trainee is developing. Ultimately, and that gives you better feedback as a unit as well if you're addressing those issues.
Good, thank you. That's really helpful.
So I think a lot of trainees are feeling quite anxious about the sort of refocusing of work-based placed assessments. Could you maybe sort of focus on how we are to use our work-based placed assessments now?
Yeah, definitely. The work-based assessments now are very specific. They're stipulated of where you use the case-based discussions, the KECs, the procedural-based assessments, and the MSF. The important thing to say, and even now at 2 years, it does bear repeating, is that there isn't a number requirement on an annual basis. Trainees shouldn't be going around looking to get additional PBAs just to get to their ARCP. That number requirement has gone. Again, look at the syllabus and the curriculum, look within the appendices, it'll tell you those that are required. So the procedural based assessments now are essentially for the index cases. There should be, and if there isn't completely, we're working on it, there should be the relevant PBA for each procedure. And the trainees, when undertaking these, should ideally be showing their journey towards competence at level 4. So if you're in phase 2 and you've done an index case and you want to do a PBA, we're not expecting you to get level 4. And you think, well, why do I do it then? Because actually the curriculum says I just need 4 at level 4, or whichever it is, or I need 10, and 4 of those need to be at level 4. I want to get that. The important aspect is that it's assessing you within that index case, and it's part of your journey towards level 4. There'll be some bits that you are doing to a level 4, as if you were a day 1 consultant. You could do it again without any degree of input, but there's some bits that are going to need to have a development. So it's important to raise that. So that's how you should be using the PBAs. If it isn't an index case, what I tend to do now is suggest that a trainee uses a case-based discussion to represent the procedural-based assessment that they've undertaken, because you can use free text, you can highlight the things that they've done well, and the things, the points that it needs to of development. It may be that procedure was something that was discussed in a previous MCR, of something that needed point of development. And so you can use that discussion aspect to highlight what you've learned and how that procedure had gone, what your learning points were, what your development points were, and whether or not it has addressed the issues or you're beginning to address the issues that are previously raised in the MCR. A lot of us feel, and this is a thing that senior trainees maybe not appreciate, but I think it's good advice, is that when you become a consultant, you spend a lot of your time assisting, but you're assisting doing a lot of the operation. So that's an important skill to develop and learn. So being a very accomplished assistant and discussing that and highlighting that within a form of assessment, you can utilize CBDs for that as well. So it's not wasted time assisted at any level, and it's certainly really valid to undertake a work-based assessment if you can do, if it feeds in to your development. And it's certainly, I think, therefore helpful to refine or develop techniques. And within those CBDs, the trainers can give really constructive action points. That's what they should do anyway. Constructive action points in relation to feedback. So, from a trainer's point of view, think WBAs, think constructive action points. Let's get away from just need to do a bit more or just do it again in relation to really focus on if they did this differently, they would do it better in relation, or if they didn't need to practice a skill, what is it by repetition that's going to make that better? And again, the WBAs are often undertaken and can be used as evidence of learning for point of development, as I said, within the MCR. So in recap, look to see what your requirement is regarding critical conditions and index cases, and when those come up, think, can you do a work-based assessment related to this? Don't worry about the level, it's the development. If it's not part of that list, but you feel it's developmental, then there are other ways to utilize the work-based assessments. It's not a mandatory requirement, it's part of your development. And if it's part of that development and you're doing it as a trainer, give them some action points, give them something to develop on.
Yeah, that's really useful. I mean, I just want to stay with the WBAs, remember, because I think that point you make about assisting is crucial. It's an important skill, but it also is an important learning time in the operating room. It isn't just doing the case as the first surgeon, but time spent in the operating room provides a rich environment for learning. So that's important. And then the other thing is I just want to clarify with you, some of the curriculum, such as ours in cardiothoracics, we've also defined major cases as well as index cases, which I know our trainees are using for their total caseload. And the PBA and the CBD would be the best way to evidence those as well.
Yeah, to highlight that you're undertaking those. But the other aspect, I would hope that there is the possibility of grouping of how those are done within the e-logbook as well. And certainly, if I was then thinking, what would I do if I was presenting to ARCP and it was part of my development, I'd have grouped my caseload into major cases to show what you've done, and that's obviously a way of checking against the gap analysis to see where you are. I would imagine in cardiac that a lot of trainees may use the terminology of how far off I am from my major requirements. How many more majors do I need to do and undertake? And I think that's valid in a way, so long as within that they've also matched it to the number of index cases, PBA's requirements that they need to do. That would be a bad thing to go out. You don't want to go into your final presentation with a misunderstanding, and that's why it's important to continue that gap analysis. It's part of that feedback conversation. So if I, again, as I was a trainee, I'd put that into my learning agreement conversations to say, you know, if you said, oh, I'm a bit worried because I'm all right on the majors, but that one I'm lower and I'm not sure I've got my trajectory, then don't just wait for it to happen. Raise it, part of the conversation, part of the adjustment. AES, come up with a plan, how you're going to address it. Check the next time with the MCR whether or not it's being addressed, and whether or not you're still below the line, or whether or not you've compensated. So that would be the way I would be suggesting about doing that. I hope that answers the question.
Yeah, no, it does. I think it's important to be proactive for the trainee to, as you say, undertake that gap analysis, use information. Now, I just want to change tack a bit, man. A question about the MCR. Is the midpoint MCR really necessary?
Oh, I know why you're asking. I am going to say yes. So just a little recap in relation to the within a placement, one MCR is mandatory required. By that, I mean that the final MCR has to be completed to allow you to sign off the end point of the learning agreement, and therefore produce a report from EAS that goes forward to ARCP. So that one has to be undertaken. The only reason the second or the earlier midpoint wasn't mandated is because we felt that since there were some existing 4 month placements, that it was perhaps too much. Now, some people have managed to do it within 4 months, do a midpoint and an end, but a lot of people felt that that might be too much. So I would say that midpoint MCRs are only needed in placements that are 6 months or longer. And when I see that, I know people go, well, you know, I'm going to be placed for 12 months, but I'd divide it into 2 learning agreements. I'd think about things as learning agreements, and the shorter that if you reduce it down to a 6-month learning agreement, the development will be better because you'll do it one over 6 months and one over the next 6 months, as opposed to just one point at the midpoint and one that gets lost towards the end. That, by dividing into 6 months, allows for 4 MCRs a year, and that it does give you good development. We're seeing the evidence that suggests if you have a midpoint MCR, the developments and the positive aspects of your end MCR, and therefore the achievement of your objectives within your final learning agreement, is better. So there is showing evidence that the MCR is beneficial. Why would you undertake it? Because an early midpoint MCR can show the targets for development, highlight some aspects, show what you're going to get out of the placement, and address whether or not the trainee is on track. So, you know, that's an early self-assessment, show where you're from your gap analysis, what needs to be developed, and therefore you can see whether or not that has occurred either within that placement or early in the next learning agreement. So the other aspect is that it helps ensure, by raising it early, that the trainee's learning style, again coming back to it, but making sure that can be considered within the early in the learning agreement within that placement, in case there needs to be a change in the way the trainee is taught, in a change of teaching style. I would stress to people to remember that if you're going to do it, make it count. And so if you are doing a midpoint MCR, it needs to be completed before the midpoint learning agreement's been signed off. If it gets slightly out of sync and the lead CS doesn't get it signed off before the AES thinks I'm going to do this, then you can't utilize it. Get signed off. But the AES is the person that ultimately signs it off, so they should be able to get that synchronization sorted out. And reminding that if you've done a midpoint MCR, you can't think, well, I've done my one MCR for this placement, I don't have to do another. The link, the signage linkage, and that's just the way we worked it out from a technical aspect, so it does exist, but also we think it's really important is that final MCR is linkage that has to be done to enable the final learning agreement to be signed off. From a trainee's point of view, I wouldn't want people to worry about finishing a placement and then suddenly finding, oh, my supervisor hasn't been able to sign it off and I won't be able to start the next one. You can start a new placement without having signed off and completed the previous one, and we actually found that there are a fair number of people whose placements are signed off, the learning agreement signed off, the final MCRs being signed off at 120%, so 20% after the placements gets, but it is getting signed off, and that, so I wouldn't be too concerned about that linkage. And the other thing I was going to say for the trainers and the leads, yes, it is also that you'll get instructive feedback from the midpoint MCR, or giving instructive feedback. It's really helpful for the trainee to potentiate their progression. So highlight it as early as possible, get the most out of that placement. And again, and I've referenced this point before, but I think it's really important at any feedback session to be identifying some action points, some really substantive action points to enable trainers to concentrate on something point forward development. Likewise, if I was a trainee, I'd be feeding back at that point in the feedback session to give points of development that relate to learning style and how trainers might be able to do things better.
Thanks a lot. That's really been very helpful.
So one of the things that's raised quite frequently amongst trainees is the feeling that the MSF and the MCR are not dissimilar. And a lot of people are asking, why do we need to do an MSF as well as an MCR in each rotation?
Yeah, a good question. I get asked that a lot. We feel that the MSF, the multi-source feedback, gives feedback from a broad range of contributors, so outside of the consultant body, and actually it gives a trainee lots of feedback and points that they may want to consider or put into their self-assessment that's then reflected against the MCR, because they're using feedback from other sources, so be it nurses, secretaries, para specialties, your peer group in relation to training level, trainees at a lower level. You know, it's the only way, unless you're getting defined feedback on teaching, to get feedback from the people that in your firm that are below you and how they feel you deal with them. Anonymous feedback in relation to, and because that may not come up with the MCR, because the consultant's perception of what it looks like may be different. So I think it's really, I do think it's really important. The MSF is there to assess professional competence. It's there to assess probity, health. It has a safety assessment, because it's about multi-professional team working environment. It focuses on constructive feedback in the workplace that can be given. You know, seniors, consultants can still give feedback within the MSF, but as I said, other juniors and your peers giving first-hand feedbacks that are specific aspects about how you deal with clinical care, what your record keeping might be like, you know, what patient safety considerations you give. Are you very good at it? Are there points for development? What's your decision making like? How does your decision making come across? What's your communication like? How does your communication come across to other groups? It's much broader than that, just that the consultant body see, and that's why it's there. It feeds back into the education supervisor. He can get an interpretation to raise. Is there a point of development here? But also within the self-assessments, you can back up some of the evidence you've got. Say, I think I do this really well. Look, lots of other people think I do this really well, because that's been fed back to me. The MCR is a much more holistic judgment by those who inhabit the consultant role. So the trainers are simply assessing you against the defined level of seeing that as a day one consultant, or when you're appropriate for phase in training. They're the people there to assess your readiness for consultant practice. The MCR can use bits of the MSF if you provide it, if the trainees provide it as part of their self-assessment, or the educational supervisor may give comment to it as part of their notage at the end when they're signing the MCR off. The MCR is all about assessing you towards your readiness for consultant practice, and it also makes a judgment about the quality of your educational, your quality improvement work and your research work. Far more defined aspects that aren't assessed in the MSF. You're not expecting one of the physio colleagues from the ward to give impact on your quality improvement, unless that's a way to raise something that you've done in corporation. So in vascular surgery, how something is done well about their interpretation and assessment, ensuring that amputation patients rehabilitate appropriately. It's not just about the operation. You know, people's interest in how well their wound heals, what the stump looks like. Is there a way that they can get some grading assessment about how good that they are? That sort of stuff could come out from a conversation and feedback within an MSF. It wouldn't necessarily appear in an MCR, but it could get referenced and put into the MCR. So hopefully that explains the importance of the MSF. Reiterate, all of these questions come up, and I completely understand why people ask them. The important thing to feedback on, and hopefully it's come across, is that they're there for developmental benefit. The whole purpose of the portfolio is to document development towards the standards, a higher level outcome that is that being a day one consultant. That's the beauty of the 2021 curriculum, is that it allows that. So these are things that are done for benefit, the benefit of a trainee's journey. And so what should that journey entail? We'll start off by reading the descriptor, the guidebook. That's the curriculum, that's the syllabus. Read it, see where you are, and progressional. And the important thing from the trainer's point of view is that I think feedback is the most important aspect. How you give the feedback and how good in quality that feedback is. And if you're giving points for development, that's surely got to be better quality than just carry on doing what you do. Hopefully that all answers the questions.
Yeah, that's some great tips. Yeah, great tips. And I think especially on how to document development, making the work-based place assessments and the whole of ISCP work for us. So thank you for all the helpful advice.
Brilliant.
Yeah, it's been really useful, Keith. Thank you very much indeed.
Thank you.